The title for this session is Maximizing Health Reform and Medicaid Redesign Initiatives to Sustain Innovation in Child Welfare. The moderator is Bethany Miller from the Children's Bureau. The session took place at the 17th Annual Child Welfare Waiver Demonstration Projects meeting. The meeting was held on September 1st through 3rd, 2015.
Good morning, everybody. I'm Bethany Miller. I think you know me. Thanks for coming into DC today, and it is now my pleasure to introduce and welcome back, Sheila Pires for our first plenary session this morning. Sheila Pires is a founding partner of the Human Service Collaborative of Washington, D.C., a policy and technical assistance group specializing in child and family service systems. Ms. Pires has more than 30 years' experience in national, state, and local government and nonprofit agencies serving children, youth, and families at risk. She's held senior staff and management positions in the United States House of Representatives, the United States Department of Health, Education, and Welfare, and the Carter White House. She co-chaired the Children's Mental Health and Substance Abuse Committee of President Clinton's Task Force on Healthcare Reform, and co-authored the Children's Issue Brief and Policy Recommendations for President Bush's New Freedom Mental Health Commission. She serves as a senior consultant to the Children in Managed Care Program at the Center for Healthcare Strategies, and is on the boards of the National Federation for Families for Children's Mental Health and the National Wraparound Initiative. At the state and local level, Ms. Pires served as Deputy Commissioner of Social Services for the District of Columbia, and prior to that, led a reorganization of the city's child mental health system as head of Child Mental Health Services. She's consulted with many states, counties, cities, neighborhoods, and family organizations, and has authored numerous publications on systems change, including Building Systems of Care, a primer or a primer, whatever your preference is. Ms. Pires received her bachelor's degree from Boston University and a master's in public administration from Harvard. She's an avid runner and tennis player, I learned this morning. So please join me in welcome Sheila Pires.
A pause while Sheila Pires approaches the microphone.
So good morning, everybody. It's nice to be back here again. And how many of you were here last year, at last year's 40 waiver meeting? Okay, you have to promise me that you'll still listen, like don't fall asleep, because this is a little bit more technical, maybe, discussion than Commissioner Lopez, who indicated he was speaking on behalf of the president. I'm speaking really on behalf of the presidents over the last 40 years. I just want you to know. I say that only because, at least for 40 years, we've been saying almost the same thing in terms of the importance of home and community-based services for children, youth, and young adults and families that we are working with, and the importance of Medicaid to this population. And so I'm going to talk today about a number of things. I'm going to talk about trends in health reform, both Affordable Care Act, but also health reform smallly written, because states are involved in health reform, even if it's not under the auspices of the President's Affordable Care Act. Medicaid redesign, and the importance of those to child welfare. Customization of Medicaid, ways of approaching Medicaid redesign and health reform that make sense for the child welfare population. Engagement of state Medicaid agencies, and Medicaid and cross-agency financing. I'm going to try to do this in 10 words or less. Now, I'm going to try to do this and also leave some time for you all to ask questions or contribute things that you're doing from your own states and communities. Many of your states I'm currently working with, probably some of you. Now that I have my glasses off, I can't see, so I can't tell. It would be useful to share what you're doing with one another, because there's no sense in reinventing wheels. These next two slides I stole from the Children's Bureau, I readily admit. I want to make the point, though, that you all know very well, that social and emotional well-being are very much linked to safety and permanence.
The slide shows the word well-being in a circle at the center with a photo of children. Well-being is linked to 6 other surrounding circles that read as follows. 1. Feeling safe and stable in the living environment. 2. Belonging and social connectedness, or permanency. 3. A sense of self-efficacy based on developing competencies. 4. Positive self-image. 5. Ability to sustain positive interpersonal relationships. And 6. Ability to manage emotions and regain equilibrium when upset. The slide was adapted from Impact Youth Services 2011. www.impactyouthservices.com/goals.htm. Also from ACYF CB IM 12-04. Found at http://www.acf.hhs.gov/programs/cb/IM1204.
I'm going to spend a fair amount of time talking about Medicaid as it relates to mental health, behavioral health, mental health and substance use treatment services, where there's also this enormous overlap, as you know, between trauma and mental health.
A bar graph shows the overlap between trauma and mental health symptoms in children in foster care. More than 13% of children in foster care ages 0 to 6. More than 39% of children ages 7 to 12. More than 54% of children ages 13 to 16. And 62% in youth ages 17 and over.
It is true that children in foster care are not as healthy as Medicaid children in general, and Medicaid children in general are not as healthy as children in general. But children in foster care, it's the behavioral health issues that are so difficult to grapple with. Even if children have chronic physical issues in foster care, it's often things like asthma. Not that they're dealt with correctly, but there are well-developed protocols for asthma treatment. These are populations of children that are very unlike adult populations, for example, with serious mental illness, where their healthcare costs are driven by physical healthcare needs because of the comorbidity between mental health and chronic illnesses such as diabetes and heart disease and cancer and chronic obstructive pulmonary disease. You don't see those types of things in children. You see things more like asthma. Okay. Why are health reform and Medicaid essential? This is kind of a no-brainer, but it's worth saying again. Most children in foster care are Medicaid eligible. Most children remain eligible when they leave foster care. Wisconsin is here, maybe? And you can raise your hand, I won't see you anyhow, especially because you're way in the back. But you guys did a study and found that 85% of children who leave foster care are Medicaid eligible. That's going to be even higher in states like Mississippi and Louisiana with high poverty, with even higher poverty rates. And child welfare was not intended to be a health or behavioral health care delivery system. When I was running children's mental health in DC, we were spending about $20 million on children's behavioral health care at the time. We thought we were, that was good. Then I jumped over, was Deputy Commissioner of Social Services, child welfare. We were spending $75 million on behavioral health treatment. A lot of it in out-of-city residential treatment placements, treatment centers. So achieving social and emotional well-being outcomes require an effective child welfare and Medicaid delivery system. You can't do it on your own in child welfare. I work with child welfare agencies, and how many years have we been struggling to try to get good behavioral health care in place without Medicaid at the table? You're sort of out here and you're saying, wait, what about us? And it's difficult to get the attention of Medicaid agencies because while the foster care population is a high-need, high-cost population, they only represent about 3% of the overall Medicaid child enrollment. Medicaid agencies are worried about the elderly, what they call the duals, those that are dually eligible for Medicare and Medicaid, adults with disabilities, general access for children in general. So trying to get their attention, it's not easy. Some of you have, though, and that's why you need to talk with one another, and I'll talk about actual state examples. Okay, so health reform trends. Medicaid redesign, there's a renewed interest in managed care, including moving very high-need populations like children in foster care into capitated, risk-based managed care arrangements. You give the dollars as the state purchaser to the managed care company. You say, go do wonderful things, and by the way, you're at risk, and I don't care if it costs you more. I'm not spending any more as the state purchaser. So my incentive as a managed care company is to keep people from using services from a financial standpoint. Now, there are lots of contractual requirements that you can do. There's monitoring. And I could be doing that in a very good way with prevention and earlier intervention. And so, okay, there was a renewed emphasis on integrated care. Who has not heard the term integrated care? Okay. I bet you we could find as many definitions of integrated care as there are tables in this room. So integrated care at a purchasing level is where a state Medicaid agency takes its behavioral health and its physical health dollars and puts them in the same managed care arrangement. Integrated care at a practice level is where you're trying to bring primary care practices and behavioral health providers together, usually through co-located services. You'll station a mental health provider in a primary care clinic. You might even do something where you're trying to get people to work as one entity with a common practice approach, but it's at a practice level. I think everybody would agree that integrated care at a practice level, more coordinated care, makes sense. You want better coordinated care between physical health and mental health. But I'm going to turn to integrated care at a purchasing level in just a second. Accountable care organizations. How many of you your state is implementing or has implemented accountable care organizations?
A few audience members raised their hands.
Okay, so here's the other situation, is that because everybody's so busy with you've got so much on your plate, trying to pay attention to what's going on in Medicaid and what they're doing, it's difficult. And, there are at least 3 or 4 states in this room that are implementing accountable care organizations. Illinois is, Colorado is. I don't know if Oregon's in the room, they are. There are a number of states that are, and I'll return to those in a moment. Okay, and then an interest in various Medicaid options, which I'll talk about. Definitions are critical, and you have these slides. They may not, these are generally accepted definitions for these terms. You may be using different definitions in your states. The importance is to have the conversation about what do you mean by integrated care? What are we talking about? A behavioral health carve-out, for example. That doesn't mean that behavioral health services are left out of managed care. It means that they're in their own specialty managed care arrangement, separate from physical health care. A left out is when you leave populations or services in a fee-for-service arrangement. Increasingly, fewer and fewer services and fewer populations are going to be left out of managed care arrangements. Administrative service organization, for example, is where you're paying a management entity to manage the system, but it's typically not risk-based. New Jersey, for example, is an example of that. An accountable care organization is a network of doctors and hospitals that share financial risk and medical responsibility for providing coordinated care. And the states that have been rolling out accountable care organizations, they're still really wrestling with how do we bring behavioral health into play. Colorado, for example, that has both accountable care organizations and behavioral health carve-outs right now, is looking at, okay, how do we bring those together in 2017? Which sounds like a long time away, but this type of planning, it takes a while because it's not easy. All right, so let's talk a moment about trends. There are 3 states that I can think of, Georgia, Florida, and who's the other? Texas, that are implementing a foster care carve-out. That is not a left out, it's taking the foster care population and putting them in their own specialty managed care arrangement, right? Texas had the first, Georgia's doing it, and Florida. I want to just give you a caution about this approach. Because you think it makes sense. You think, oh yeah, that makes sense. Then we can get everything we need for our populations of children. First of all, children who are enrolled in Medicaid through TANF, low-income children, or for disability purposes, children on supplemental security income, they need the same array of services and supports as children in child welfare. That's number 1. Number 2, children don't stay in foster care forever. The median length of stay in 2012 was 13 months, but they often still have a need, particularly for behavioral health services, and of course also for physical health services. And it may be the behavioral health services that keep them from bouncing back into child welfare, right? If the foster care specialty arrangement has a different benefit, a richer benefit, covers more home and community-based services, covers more trauma-informed care, covers a different provider network, that child is going to lose those services and continuity of care when they leave the foster care system. The other thing is it leads to unintended consequences of families having to relinquish custody to get services for their families. And that's still a phenomenon, as you know, in a number of our states. And that's particularly the case if you have a child with a serious behavioral health challenge. And you can't get what you need out of the mainstream Medicaid system. So, integrated physical and behavioral health care, right? Just think about it from a common sense standpoint. Commissioner Lopez was talking about we know this based on data. We also know it based on common sense. If I'm the purchaser and I give this managed care table right here all my physical and behavioral health dollars to take care of adults and children and youth, physical, behavioral, and often dental care, oral health care as well, there's a risk of the physical health dollars, or the behavioral health dollars rather, being eaten up by physical health care, because that's what takes up a lot of the airtime. And there's a risk of the child behavioral health dollars being eaten up by adult behavioral health care, because adults tend to take more of the dollars. So it's not that you can't do the kind of customization that's needed in an integrated arrangement, but the lift is heavier than if you have a carve-out. Having said that, though, the integrated train has left the station. Everybody's drunk the integrated Kool-Aid, as I call it. They're all moving down this integrated path, thinking it will lead to better coordinated care. That has not been our experience to date. Tennessee has the oldest integrated care model, and I would say, I don't know if Tennessee here? Are you here? Okay, I can say whatever I want about Tennessee. No, they're back there in the corner. Okay, so, and I would say that you guys have done many things really well. I think you're still grappling with, and you've got some pilots going around the population of kids that have significant behavioral health challenges and are involved in multiple systems, including child welfare. Trying to get, and you're working on that now, I know, through some pilots. But widespread, the integrated designs, we don't yet see that they're customized enough for children in child welfare. So that doesn't mean you're going to change the integrated approach. I mean, the fact that your states are doing an integrated approach, but you've got to be at the table to make sure they encompass what you need for children in child welfare. By the way, I keep going back and forth between, when I talk about Medicaid, between children in foster care and children in child welfare. The problem is that in Medicaid systems, you can typically identify children in foster care through the 4E entitlement, but you can't identify typically the larger population of children involved in child welfare, and that's an issue. Integrated care at a practice level. We have medical homes and we have health homes.
Medical homes serve all children, coordinate medical care, and involve physician-led primary care practices. Health homes serve children with chronic health conditions and serious behavioral health conditions. Health homes coordinate physical, behavioral, and social supports and involve specialty provider organizations, including behavioral health specialty organizations.
Wisconsin, for example, is doing a medical home for the foster care population in a 15-county region. But they're partnering with Wraparound Milwaukee, which is a specialty managed care arrangement for children with significant behavioral health needs, including children in child welfare, for any children that need more. And that's important, and I'll show you why in a second. Health homes, so medical homes, really every child needs a medical home, which is designated primary care provider, right? That's different from a health home, and people use these terms interchangeably, and they're very different. Health homes is a provision of the Affordable Care Act, and it is meant for chronic populations. We don't typically talk about the children that we serve as a chronic population. But the way they use services and the cost associated with those services, they are in fact a chronic population, and the Act recognizes that. And there are 2 states that I know of, and I can't think of any others, that have customized and gotten approval for health homes that actually are based on evidence of what works. One of them is Oklahoma. Are you in the room? Where they built on a wraparound approach with a fidelity wraparound approach, and the second is New Jersey. I don't know if New Jersey's in the room. Okay, and I'll show you some examples of those two. So there's been a fair amount of research done on medical homes and for children, particularly with significant behavioral health conditions. All behavioral health conditions except ADHD were associated with difficulties accessing specialty behavioral health care through a medical home. Again, you don't need the research. Think about it, common sense. I'm a busy pediatric practice. I'm going to get an extra $12 per child per member per month, per child per month, to do better coordinated care. What am I going to do? I'm going to hire a nurse care coordinator. She's going to have 250 children on her caseload, and she's going to make a lot of telephone calls. That's what a medical home care coordination model looks like. That doesn't work for children who have significant needs going on. Family needs, court issues, they're involved in multiple systems, etc.
Slide includes a citation for Medical Home Services for Children with Behavioral Health Conditions from the Journal of Developmental Pediatrics.
There is another trend, and I'm talking about trends also that are predominantly on the screens of Medicaid agencies.
The source for the slide is the webinar entitled A Health Home Run, Operationalizing Behavioral Health Homes, hosted by the Center for Integrated Health Solutions, U.S. Substance Abuse and Mental Health Services Administration, January 2013.
Customizing care coordination for individuals with chronic conditions. For children in child welfare with significant trauma and behavioral health challenges, neither traditional case management nor the kind of care coordination done by a managed care company, which tends to be telephonic or by email, nor care coordination approaches for adults are sufficient. You need an approach that's based on evidence. The only one I know of is fidelity wraparound, intensive care coordination using fidelity wraparound. There's starting to be some research around a collaborative care management model that came out of the adult world. We're seeing some early results on adolescents with depression, but it's a different population from the populations of children and families we're talking about. You need lower case ratios. In a fidelity wraparound approach, the care coordination ratios are 1 care coordinator to no more than 8, at the most 10 families. The Missouri, just in contrast, the Missouri Health Home approach, a care coordination model, is 1 care coordinator to 250 persons. You need a higher intensity rate for care coordination for children in child welfare and children with significant behavioral health challenges. We did a scan through Center of Healthcare Strategies. The care coordination rates for our populations of children in a fidelity wraparound approach range from about $780 per child per month. That's Wraparound Milwaukee's. They're very good at what they do. To as high as $1,300 per child per month. They average out at about $1,100 per child per month. The care coordination rate in the Missouri Health Home model is $78 per member per month. So when you have these discussions with your state Medicaid agencies, their initial response is to have heart failure. They go, oh my gosh, how are we going to pay for that? But what you're doing is if you give a care management entity or a high-quality wrap team embedded in a supportive organization, you give them a rate that makes sense and mandate the care coordination ratios and fidelity to the model, you see reductions in inpatient psychiatric use, rebounding in and out. You see reductions in the use of emergency rooms. You see reductions in the use of residential treatment facilities, which a lot of, not only psychiatric residential treatment, but other residential treatment centers, which a lot of Medicaid agencies are paying for, at least paying for the therapeutic costs of care. You see reductions in the use of therapeutic group care. You also can see reductions in the use of psychotropic medication, and you can also see reduced costs on the physical health side. Those are the data you have to bring to the Medicaid agency to say, this is why this makes sense. And if you don't do something different, the costs are just going to continue to go up because the cost of health care, inpatient, residential, just keeps going up every year.
A growing number of states are using intensive care coordination approaches to facilitate better outcomes, lower per capita costs, and improve family/caregiver and youth experience. Examples include California, Massachusetts, Louisiana, New Jersey, Wisconsin, Illinois, Maryland, Georgia, Wyoming, and Oklahoma.
Right? Okay. The intensity of the approach needed with children and families is just much different from adults. And the involvement of other systems, child welfare, education, the courts, juvenile justice, and most of those systems have legal mandates to serve children, so you can't ignore them. It's just a huge intensity of approach. These are, Fidelity Wraparound. I want to just say a little bit about. Some of you have Fidelity Wraparound in your 4E waiver plans. It is increasingly showing up on evidence-based practice clearinghouses.
3 examples of institutions that consider the Fidelity Wraparound approach to be evidence-based are 1. The California Clearinghouse for Effective Child Welfare Practices, 2. The Oregon Inventory of Evidence-Based Practices, and 3. The Washington Institute for Public Policy.
States are implementing this model either through care management entities, so a designated entity that's doing this approach and is accountable for outcomes, or high-quality wraparound teams, as in the case of Oklahoma, which they've embedded in their community mental health clinics. New Jersey, this is a picture of New Jersey.
The slide shows a diagram of the Children's Behavioral Health carve-out in New Jersey, which was a partnership between Medicaid, child welfare, and mental health. The Child Welfare Agency, the Department of Children and Families, managed the partnership with funding from Medicaid through a contracted systems administrator, Perform Care. Training and technical assistance provided through Rutgers. Perform Care provided a 1-800 number, screening, utilization management, and outcome tracking. They also managed family support organizations, care management entities or CMOs, and the provider network. Family support organizations provide services for family peer support, education and advocacy, and youth movement. Care management entities lead nonprofit agencies managing children with serious challenges and multi-system involvement. They are now health homes. The provider network included mobile response and stabilization services. This information was adapted from the state of New Jersey, 2010.
I find this a very interesting system. It is a children's behavioral health carve-out. So it was a partnership between Medicaid, child welfare, and mental health. They took dollars that child welfare was spending on Medicaid-eligible children for services that could be medicated. That often gives child welfare directors heart failure too, because if you give up your dollars and you don't get what you need from the system, then you're really in trouble. So this really has to be a partnership. That's what New Jersey did. They created a carve-out. They set up the Medicaid agency as the single-payer system, so that the system serves both Medicaid-eligible and non-Medicaid-eligible children. You get a Medicaid look-alike card if you're not a Medicaid-eligible child. Single-payer system, because they thought Medicaid had the best data system to do the claims processing, et cetera. But from a policy standpoint, there's a state interagency team, and it's the Department of Children and Families that actually oversees the carve-out, not the Medicaid agency, although they're a partner on the team, obviously. They created locally based care management entities, which are nonprofit organizations that provide intensive care coordination using Fidelity Wraparound. They partner with family-run organizations that are families who have lived experience, and they're increasingly partnering with youth move chapters, which are youth-run organizations or movements in the state. They use the Child and Adolescent Needs and Strengths tools, the CANs, which many of you in the 4E waiver states are using. They put in place mobile response and stabilization capacity across the state. A newer generation, not like the old model where you go, you stabilize, you hand off your gun. This model defines crisis very broadly. It allows a team to work with a child and family, with a group home, with a school, to over a 30-day period or longer. It can provide one-on-one crisis stabilizers. There are several states using this model. Wisconsin has a very good crisis benefit where you can do lots of creative things under it in Medicaid. And if you build on Medicaid for your behavioral health service system, things like crisis response, peer support, intensive in-home services, behavioral management consultation, all of these things can be reimbursed under Medicaid. You're drawing down at least 50% federal match dollars, so you're expanding the capacity of the system. That's why it makes sense to build on Medicaid. Besides which, child welfare, you're not a health and behavioral health delivery system. And Medicaid is going to continue to do weird things for your populations of children unless you're at the table getting them to stop doing weird things.
The slide presents a diagram showing the Massachusetts system of care. Medicaid worked with multiple locally based managed care organizations. These locally based care management agencies, called community service agencies, are nonprofit behavioral health and specialty providers that ensure child and family team plan of care, provide intensive care coordination, provide peer supports and link to natural helpers, and manage utilization, quality, and outcomes at service level. This information was adapted from the state of Massachusetts.
Massachusetts was based on a Medicaid approach because it was a early periodic screening, diagnosis, and treatment lawsuit, an EPSDT lawsuit. How many of you know whether you have EPSDT lawsuits in your state?
Only a few audience members raised their hands.
Okay, probably half of the states right now in this room have EPSDT lawsuits. Many of you also have child welfare lawsuits. It makes no sense for the child welfare lawsuit folks to be over here doing one thing and the EPSDT lawsuit folks over here doing another thing when it comes to social and emotional well-being. Those EPSDT lawsuits are all about a lack of home and community-based services. That's what they're about for children with behavioral health challenges. You know, in these care management entities that I'm talking about, or on high-quality WRAP teams, for example, probably 2/3 of the children are involved with child welfare and or juvenile justice. Probably 60% of them have special ed plans through the schools. So, okay, Massachusetts has locally based care management entities using the same model. So then they had to work with the managed care companies, and there are 6 of them, to have common utilization management criteria, because in a fidelity wrap approach, the child and family team develops a plan of care, and there's integrity to that plan of care because it's driven by the family and the youth and what they feel will make sense. Obviously, other partners are involved in the process, but so if a managed care company gets the plan of care and says, well, we'll approve this piece, but not this piece, and they start nickel-diming the plan of care, as I call it, you're destroying the integrity of a fidelity wrap process. So you have to work with your managed care entities to understand what you're trying to achieve. And so they've developed common utilization management criteria for those plans of care. This is a picture of Oklahoma, which built on its health home based on what works. So for the adult population, they built on an assertive community treatment and ACT team model. There's evidence showing that works. For children, they built on a fidelity wraparound approach. Okay, and one other thing I'll say is that this approach lends itself to co-financing, to blending funding, and I'll show you some models of that, because many of the outcomes you're trying to achieve, placement stability, redirection from, or reduced use of out-of-home placements and reduced use of residential treatment, for example, and lengths of stay. These are the same outcomes that these approaches are trying to achieve that may be coming out of Medicaid and or mental health.
A slide is shown that presents 6 strategies for lowering costs and improving outcomes. 1. Redirect dollars from high-cost, poor outcome services. For example, hospital, emergency room, residential detention, and group homes. 2. Invest savings for each youth served in-home and in a community-based capacity. 3. Promote diversification or re-engineering of residential treatment centers. 4. Use population-based, all-inclusive case rates or bundled care coordination rates. 5. Use population-focused quality and outcome indicators. And 6. Use population-based purchasing approaches tied to performance.
Georgia is an example of a state that is set up a care management entity infrastructure. So they're nonprofit organizations understanding these populations that are charged with doing a fidelity wrap approach, and the contracts call for the outcomes that I've just mentioned. Each of the alphabet soup on the right-hand side are payers. They're purchasers of services. They can buy into those regional care management entities for managing a subset of children that could benefit from that approach.
A slide is shown that presents a diagram showing the system of care in Georgia. Georgia has a care management system that allows any state agency to participate. The agencies listed on the slide include Department of Community Health, Department of Behavioral Health and Developmental Disabilities, Department of Family and Children's Services, Department of Juvenile Justice, and Department of Education. This slide is adapted from the state of Georgia.
So if you have the infrastructure in place, any agency could buy into it. So right now, the Amera Group is managing the foster care population, and they have finally agreed to contract with the regional care management entities. Because after a year, they're realizing, oh, what we thought we were doing is not really making sense. And then, so the other agencies can also buy into it. So, juvenile justice can, as a detention diversion strategy. Okay. RAP Milwaukee is one of the oldest of these approaches. I'm sure most of you are familiar with RAP Milwaukee. It is a blended funding model, they contract. It's managed. It happens to be managed by the County Division of Behavioral Health, Children's Behavioral Health, but they contract with 8 care coordination agencies, giving them a bundled care coordination rate, and they have, because the funding is so flexible, they can develop a provider network that's very flexible. So they have, over 200 providers, 80 of whom are culturally diverse providers. They can fund, a wide variety of services and supports using this kind of blended funding approach.
The slide shows the structure for Wraparound Milwaukee Care Management Entity, which is a mobile response and stabilization co-funded by schools, child welfare, Medicaid, and mental health. Child welfare provides funds through case rate, budgeted for institutional care for children. In juvenile justice, funds are budgeted for residential treatment for youth with delinquency. Medicaid capitation is $1,557 per month per enrollee. Mental health provides crisis billing, block grants, and HMO commercial insurance. Schools refer youth who are at risk for alternative placement. Services are provided through contracts with 8 community providers for intensive care coordination using Fidelity Wraparound, which includes intensive care coordination and a provider network of 210 providers of 70 services. A child and a family team develops a plan of care. The all-inclusive rate, which includes services supports, placements, care coordination, and family support, is $3,700 per case per month. Care coordination is approximately $780 per case per month. Slide material developed from Wraparound Milwaukee, 2010. What are the project funds?
Cuyahoga County is another. There's Ohio in the room. Where are you? Yeah. So, I think other counties in Ohio, maybe Stark County, have been trying to implement a similar type of model, and this I would call more of a braided funding approach, where you take, where you have memorandum of agreement across agencies saying these following funding streams can be used to support the plans of care that are developed in Cleveland's case at a neighborhood level, because they built on their Casey neighborhood family-to-family collaboratives.
The slide is entitled Cuyahoga County, Cleveland. The slide shows how Cuyahoga County, Cleveland, Ohio, served children at risk of entering the child welfare system using detention diversion for youth with status offenses. The System of Care Oversight Committee was over the County Administrative Services Organization, which provided funding for early intervention, family preservation, and system of care grants. These funds were provided through neighborhood collaboratives and care coordination partnerships to community providers and natural helping networks, which resulted in reinvestment of savings. This slide was developed based on Primer Hands-On by Sheila Pires, 2006.
And partnered them with their formal service providers in a Fidelity WRAP care coordination approach for not only the populations of children that are in or on their way to high-end services, but also families that are at risk for child welfare involvement because they're building on their neighborhood family-to-family collaboratives. So you can add any kinds of populations into this that could benefit from this more concerted care coordination focus. Youth that are getting kicked out of school, for example, and put in alternative schools. Most of those youth don't have individualized education plans for the schools, but they're getting kicked out for behavioral health reasons. The schools have an incentive to buy into a different model. Those alternative schools are very expensive, and they're not very effective for the most part.
The following slides were developed from material by Sheila Pires from the Human Services Collaborative.
All right, let's talk about customizing Medicaid for a moment. These are strategies, and you'll have these slides so you can go back and look at them kind of more at your leisure. But we know we have a pretty good handle on what you'd build into Medicaid design, managed care, requests for proposals, and contracts that would make a difference for the child welfare population and larger populations of children with behavioral health challenges. So for example, a number of states have presumptive eligibility. So if a child comes into foster care, presumptively that child is eligible for you don't have to go through some large process to get the child Medicaid eligible. Continued eligibility for youth transitioning out of foster care, as you know, is a 2014 went into to place for youth to age 26, part of the Affordable Care Act. States also, though, have transition coverage policies upon leaving foster care at any age. So Arizona covers, 60 days, provides 60 days of coverage after exit from foster care. And for youth that are in juvenile justice, and many, of course, many of children in youth and child welfare are also involved in juvenile justice, suspend rather than terminate Medicaid eligibility. You can also, by the way, use Medicaid for youth in detention if they are pre-adjudicated, or if they've been adjudicated and they're awaiting placement for a community-based, like residential treatment, for example. Even Centers for Medicare and Medicaid Services gets a little confused on that and has issued confusing policies. So you talk to one regional director, you get one answer, another regional director, you get another. But their own policy briefs have come out and said, if this is a temporary placement, awaiting placement in a treatment setting, Medicaid can still come into play for Medicaid services. So, trauma-informed screening and early intervention. You can, like Massachusetts did, mandate the use of standardized screening tools as part of EPSDT screens, including behavioral health screening. You can incorporate state child welfare requirements, as several states have done. All of your states have requirements that when a child enters care, you have to have a physical health screen and a mental health screen, right? And you have timelines attached to them. Build those into managed care contracts. Why should you be paying out of your general revenue or other funds for screens? It's because you can't get them in a timely fashion. The people doing them don't know what they're doing. They aren't the right types of screens. They should be being done by EPSDT providers and include the types of screening that's needed. You might have to, you probably do have to, enhance the screening rate if you're going to do that. And Massachusetts didn't increase the screening rate because those types of screens take time. You can also give quality payments to providers who are doing trauma-informed screens or trauma-informed care. The service array, making sure there's a broad array of services covered in your Medicaid design. Cover a range of crisis options. Cover evidence-based practices. The Centers for Medicare and Medicaid Services and the Substance Abuse and Mental Health Services Administration came out with a joint bulletin back in May of 2013. It was guidance to state Medicaid directors about what should be in the plan. I would encourage you, if you don't have it, to get a hold of it. These are the services that they recommend: intensive care coordination using Fidelity wraparound, peer support services. Many of you in your 4E waiver programs have family engagement strategies, including using family and or youth peers with lived experience. That can be covered under Medicaid. Intensive in-home services, respite can be covered through various waiver programs, including managed care waivers, which now virtually all the states are getting. Mobile response and stabilization, flexible funds. You can also build what's called customized goods and services into your Medicaid state plan. So Maryland, for example, in its 1915I use of that option, has built in up to $2,000 per family per year in customized goods and services paid for out of Medicaid, right? Now, it's mainly you guys out of your budgets paying for, flexible stuff. And customized goods and services are those one-time needs, paying for an electric bill or paying for, getting a car fixed or whatever's going to make a difference. Mandating inclusion of providers in the network that know about the child welfare population. So Tennessee does that. They have a best practices network of providers that are knowledgeable about the population. Developing protocols and practice guidelines for managed care companies and providers about the child welfare population, not assuming that they know how the child welfare system runs, who are the families involved in child welfare, what is the interface with the court. Okay. Psychotropic medication oversight. There have been tons of bulletins coming out of the federal government, studies as well, a lot of research. You can put systems in place in Medicaid to monitor psychotropic medication outlier use. So for example, too young, too many, too much, too long. Those are sort of the parameters. As a number of states have done, you can build in consultation to providers that look like outliers. Why is this child on 4 antipsychotics? You can build in that kind of, Illinois does that, for example. You can orient your managed care companies to the informed consent and assent processes that are in place and protocols in child welfare. Not all of you, most of you do have informed consent and assent protocols when it comes to youth, for example. Managed care companies need to know about that. You can provide, of course, you've got to provide coverage of treatment alternatives. Medicaid, the Centers for Medicare, I found this really interesting too. They did, and it was probably because at the time, I was struggling with my father who had Alzheimer's and was in a nursing facility, and it's so difficult to try to get quality care. And there's such a tendency in nursing homes to over-medicate the elderly because of aggressive behaviors and sleep disorders. And I started thinking about that, and I thought, that's the same thing as youth in residential treatment centers. There's I'm not castigating residential providers. There's a role for residential, et cetera. But it is also a problem that in congregate care, children often are put on medication because of aggressive behaviors and because of sleep problems. So Centers for Medicare and Medicaid Services launched this national quality initiative to focus on that issue, and they got some very good results. And so we're talking about having some conversations with them to see if we couldn't launch a similar kind of initiative around children in congregate care and see if we couldn't focus on that. We talked about care coordination and the importance of that, and data and performance measures. You would probably not be surprised how many contracts don't require the tracking of utilization of any types of services by the foster care population, for example, or for child behavioral health utilization.
The slide presents 2 recommendations for improved tracking of service utilization. 1. Measures should include the specific tracking and reporting of child behavioral health penetration rates and use of services and medications, stratified by age, gender, race, ethnicity, aid category, region, diagnosis, service type, and medication type. There should be specific tracking and reporting of foster care population utilization overall, by service type. 2. In addition, performance expectations, not only HEDIS, should be included. Arizona, Michigan, and New Jersey are states that have led the way in this area.
Well, how do you know what's happening if you're not tracking it? How do you know what children are getting? The data are there, but they're not the requirements for reporting it as benchmark data or quarterly reports or whatever. Performance expectations. Most managed care companies are held to what are called HEDIS, Health Effectiveness Data and Information Set requirements. They are so thin when it comes to mental health, and particularly for children. It's things like, follow-up after discharge from an inpatient setting. They're not the kinds of outcomes or performance measures that we would find useful or robust or meaningful, really. So there are states that have built in other performance measures that and here are examples of them, that would make more of a difference. Like reduced lengths of stay in congregate care, for example. Like improved school attendance. You can require that a managed care company have periodic focus groups, for example, not only with families and with youth, which is critical, and the families and youth involved in your systems and caregivers, but also with child welfare workers who know what's going on, and supervisors who have, an ear to the ground. And you can also put in requirements about interfacing with the child welfare information system with SACWIS. That may or may not happen, but you can put it in. Hopefully it will. Utilization management, you can require no prior authorization for basic access to services, like 12 visits, okay? Then no prior authorization is necessary. You can have, but you could put in place prior authorization for certain psychotropic meds for certain populations, antipsychotics for children under 5, for example. So you can work that both ways.
2 other recommended strategies for utilization management are: 1. To require that plans of care developed through the wraparound process determine the medical necessity with outlier management, as is being done in Arizona, Louisiana, Massachusetts, and New Jersey. And 2. To require no fail-first criteria for access to services and medications.
Orientation and training. A number of states, a number of you here in the room are developing centers of excellence that are university-based to try to provide training and capacity building around a number of these things, including evidence-based practices.
The slide presents 2 recommendations for orientation and training. 1. Incorporate training for MCOs on the foster care population, child welfare system, the role of the court, and children with significant behavioral health challenges, as is being done in Massachusetts and Arizona. And 2. Incorporate training for Medicaid providers on effective practices, such as the wraparound approach in Massachusetts, Michigan, New Jersey, Louisiana, and Maryland, trauma-focused CBT and parent management training, such as the Oregon model in Michigan, trauma-informed care, as in Arizona and Massachusetts, and various screening tools, as in Massachusetts.
That's critical because people don't really, they aren't really trained in these models. So financing incentives using risk-adjusted rates, for example. That's higher rates for populations of children that are going to use more services. Incentive payments. Michigan provides incentive payments to its community mental health clinics to serve the child welfare population. Enhanced screening rates we talked about. Requiring reinvestment back into children's behavioral health and child welfare services is really critical. You don't want any per capita savings that have been generated by reduced use of inpatient or residential or et cetera to go into, larger deficit reduction or highways or adult corrections beds. Or you need to have reinvestment into these systems, and you can require reinvestment by managed care companies, certain percentages back into the children's system. Administrative requirements. Many of these arrangements do have designated liaisons between the managed care company and the child welfare. You can require periodic meetings, inclusion of families and youth and caregivers with lived experience, on quality review processes, on advisory committees, as system navigators. You could set up a warm line, not only for families, but for child welfare workers. It also helps when the child welfare system has designated child health units or staff that can interface with managed care companies, like New Jersey does, like DC does. I know DC's here. Utah does, and you can use a combination of Medicaid admin dollars and child welfare dollars to help to finance those child health units.
The slide is entitled Lessons from States: Customization for Children in Child Welfare in Medicaid. Medicaid service delivery and payment models would benefit from the following 3 recommendations. 1. Collaborative planning, design, and implementation should be a priority. 2. It is important to explore the potential for a Medicaid match from child welfare. Most children are Medicaid eligible, and many services paid for by child welfare are Medicaid allowable. And 3. State agencies need to approach implementation in partnership with managed care entities.
So collaborative planning is critical with Medicaid. So how do you engage them? How do you get their attention? Use data. If it's not your own data because you don't have it, then take the national data. We've looked at, and Casey Foundation and Centers for Medicare and Medicaid Services funded these first 2 analyses we looked at Medicaid, the entire Medicaid population of children, so some 30 million children on Medicaid, and And then we looked at how they use both physical and behavioral health care, so mental health and substance use services, psychotropic meds, and physical health care in the Medicaid system. What services do they use? What medications do they use? What physical health care do they use? What's the cost of care?
The slide is entitled Engaging State Medicaid Agencies, Use Data. Children in foster care are a high-cost Medicaid population. The slide makes 5 points. 1. Children in foster care represent 3.2% of children in Medicaid, but 15% of children using behavioral health care. 2. Children in foster care have the highest penetration rate for use of behavioral health services of any aid category of children. 32% of children in foster care use behavioral health services, compared to 26% of children on SSI and 4.9% on TANF. 3. Children in foster care have the highest mean behavioral health expenditure of any aid category of children, $8,094 per child, compared to $7,264 for children on SSI. 4. Children in foster care have overall Medicaid mean expenditures for physical and behavioral health care of $12,130 per child. The costs are driven by behavioral health care. And 5. Children in foster care who use behavioral health services have costs that are 7 times higher than for Medicaid children in general.
Children in foster care, first of all, children who use behavioral health care and Medicaid in general are a high-cost population. They're about 5 times more expensive than the Medicaid population of children who don't use behavioral health care. Children in foster care have the highest penetration rate, so the highest rate of use for behavioral health service than any other aid category of children, including children on disability. And then they have the highest mean behavioral health expenditure of any aid category of children, so higher still than children on disability. Their costs, as I mentioned, are driven by behavioral health care. Their costs are 7 times higher than for Medicaid children in general. Okay, so you can get, and the reason I talk about cost is because the triple aim of healthcare these days, the 3 things that Medicaid directors are focused on, are improving the cost of care, improving the quality of care, and improving the experience of healthcare consumers, right? But what I found is what grabs their attention first is cost. We have got things that, first of all, we can show you that these are high-cost populations of children, though their numbers aren't great, their costs are high. That we do have strategies that can reduce the cost of care and reduce the use of high-end services. And in the offing, also improve the quality of care. Okay, so children in foster care are more likely to use inpatient psych, residential treatment and therapeutic group care, emergency room services, and psychotropic meds.
In addition, children in foster care are only 1/5 the size of the TANF population, but use nearly the same amount of dollars for residential and group care and ER visits, and 3.5 times more for therapeutic foster care.
They have also very high rates of psychotropic meds, as you know. They're more likely to receive 2 or more concurrent psychotropic meds. They have a very high rate of use of antipsychotic medications, and they have the highest mean expenditures of any aid category of children for psychotropic med use.
The slide is entitled Engaging State Medicaid Agencies. Children in foster care have high rates of psychotropic medication use. The slide makes 5 points. 1. Children in foster care are 3.2% of the Medicaid child population, but nearly 13% of Medicaid children using psychotropic medications. 2. 23% of children in foster care use psychotropic medications paid for by Medicaid, compared to 27% of children on SSI and 4% of TANF children. 3. Children in foster care are more likely to receive 2 or more concurrent psychotropic medications than other aid categories of children. 49% of children in foster care, 46% of children on SSI, and 4% of TANF children. 4. Of children getting antipsychotics, 42% are in foster care, 42% are on SSI, and 18% are TANF. 5. Children in foster care have the highest mean expenditures for psychotropic medications of any category of children. $934 for children in foster care, $916 for children on SSI, and $475 for TANF children.
What drives overall Medicaid costs? Use of emergency rooms for regular care. So having medical homes in place makes sense. Use of emergency rooms for asthma-related conditions. Getting providers to implement asthma protocols are critical. Inappropriate use of psychotropic meds, and we talked about a number of strategies around monitoring, consultation models, etc. Use of residential treatment, and in some states, day treatment. Use of traditional outpatient therapies. Sometimes I'll talk with Medicaid directors and they aren't paying attention to outpatient, but they're spending a lot of money on outpatient, and they're basically buying office-based 50-minute hours inside-based therapy. There's been a number of studies done by well-known researchers in child welfare, Laura Leslie, John Lansford, that the use of traditional outpatient services really don't have much impact on children in foster care. That's what's needed are evidence-based approaches like trauma-focused cognitive behavioral therapy, functional family therapy, parent-child interaction therapy, a number of the things that are in your 4E waivers. Those are treatment programs that could be covered by Medicaid.
The slide presents 7 major cost drivers, with accompanying strategies for reducing cost and improving child and family outcomes. Cost driver number 1, the use of emergency room for regular care. One strategy to reduce cost and improve outcomes would be to use medical homes. Cost driver number 2, the use of the emergency room for asthma-related issues. To learn more about strategies for reducing costs and improving outcomes, see Achieving Better Care for Asthma, a BCAP toolkit, available at http://www.chscs.org/publications/doc/2086/doc/2096. Cost driver number 3, inappropriate use of psychotropic medications. Strategies for reducing cost and improving outcomes include red flag monitoring and consultation to and education of prescribers, as is being done in Oregon and Wyoming. Psychiatric consultation to primary care doctors, as is being done in Massachusetts, and informed consent supported by access to psychiatric consultation, as in Illinois and Vermont. Cost driver number 4, use of residential treatment and day treatment. Strategies include effective home and community-based alternatives and intensive care coordination using fidelity wraparound, as in Massachusetts, New Jersey, and Wisconsin. Cost driver number 5, use of traditional outpatient therapies. Strategies to reduce cost and improve outcomes include using evidence-based practices. The slide quotes research that indicates that, quote, based on current evidence of the effectiveness of interventions in community mental health settings, there is no reason to assume that the outpatient mental health services provided to foster children are effective in improving outcome, end quote. Cost driver number 6, duplication of services, multiple assessments, and multiple care coordinators. Strategies for reducing cost and improving outcomes, common screening and assessment tools, and a fidelity wraparound approach with a dedicated care coordinator. Cost driver number 7, longer lengths of stay and multiple placements in foster care are associated with higher Medicaid costs. Strategies for reducing cost and improving outcomes include fidelity wraparound, family finding, and strengthening families.
So for you all to spend, all child welfare dollars for the actual provision of the service doesn't really make sense. Yes, you need to partner in the training and fidelity monitoring, because it's hard to use Medicaid dollars, not impossible, but hard to use them for things like training. And they're paying attention to so many other things from a quality standpoint, getting them to really track fidelity monitoring for an individualized evidence-based practice, that's not going to happen, right? Okay. Duplication of services drives costs. So when you have multiple systems, child welfare, mental health, juvenile justice, Medicaid, all trying to build their own behavioral health delivery systems, it's very inefficient. You end up with multiple care coordinators, multiple plans of care. Okay, Chapin Hall has done some research that has shown, and again, you don't even need the research. Think about it, it's common sense. Longer lengths of stay in foster care and multiple placements are associated with higher Medicaid costs. Just makes sense, right? So there's a win-win here for Medicaid and child welfare to approach this together. So you have to move from a mentality of categorical funding of programs and grants to collaborative financing and value-based purchasing in partnership with Medicaid. What is it that you want to use your dollars for? For which populations of children and families? And then you have to strategize. Once you can figure out the what it is you want to do, what are the system design features you want to build in? You know, and that's an array of things. It's not just one evidence-based practice. It's not just peer support. It's not just mobile crisis. You know, it's an array of things. It's not just intensive care coordination. You have to really think, and you have the answers in your own heads. You know what makes for effective delivery systems for children and families. Put it down on paper, plot it out, and then look at who could finance what.
The slide is entitled, Who Can and Will Fund What? Medicaid and Medicaid MCOs can fund intensive in-home services, crisis response, wraparound, peer support, TF-CBT, FFT, MST, MDTFC, PCIT, substance use disorder treatment, screening and assessment, and workforce development. MCO reinvestment dollars can fund workforce development, CANS implementation, EBP capacity development, and psychotropic medication consultation. Child welfare can fund team decision-making, family finding, strengthening families, permanency roundtables, workforce development, CANS implementation, and psychotropic medication consultation. Other systems, such as BH, TANF, and JJ, can fund workforce development, CANS implementation, non-Medicaid families, psychotropic medication consultation, nurse home visiting, housing supports, and transportation.
Because Medicaid can't do everything. It is, after all, a healthcare system. But it has a lot more flexibility than many states are using, and do that kind of mapping. Also, managed care, well, it's my grandmother used to say it's a blessing and a curse in her Irish accent. It's a blessing and a curse. Is managed care organizations have more flexibility because they have access to reinvestment dollars and administrative dollars. So, for example, in Arizona, they trained their workforce in the incredible years, which really is a prevention model. But they were able to use reinvestment dollars to do that. Okay. Medicaid also is an important partner, and I think will become increasingly important for substance use coverage for adult family members, which is so critical in child welfare because it's so difficult to access effective substance use treatment services. And Centers for Medicare and Medicaid Services have put a big push on to try to get states to look at coming up with what they call organized delivery systems for substance use disorders treatment for both adults and adolescents. And so it's important to be in those conversations as well. But you can combine financing through Medicaid, child welfare, particularly with 4E waiver dollars. I think one of you, I can't remember who, Illinois, I think, is using your 4E waiver funds for recovery supports, for example, for adult family members. But there are a number of states, like Georgia, that pays for, out of Medicaid, peer supports for adults that have substance use challenges, and adults with mental illness, and now children with significant behavioral health challenges, and they're using both parent and youth peer partners. So, look at where it would be best to do this, because you can draw down, the federal match. Okay, so I'm going to stop there. These last two slides are just some resources, and see if you all have any 5 minutes, I guess, a burning question or what, yeah.
The first resource slide is entitled Federal Medicaid Guidance. Sources listed are 1. July 11th, 2013. State Medicaid Director's Tri-Agency Letter on Trauma-Informed Treatment. Available at http://www.medicaid.gov/federal-policy-guidance/downloads/smd-1 13-07-11.pdf. 2. May 7th, 2013. Informational Bulletin on coverage of behavioral health services for children, youth, and young adults with significant mental health conditions. Available at http://www.medicaid.gov/federal-05-05-07-2013.pdf. 3. March 27th, 2013. Information Bulletin on Prevention and Early Identification of Mental Health and Substance Use Conditions. Available at http://www.medicaid.gov/federal-05-03-2013.pdf. 4. August 24th, 2012. Informational Bulletin on Resources Strengthening the Management of Psychotropic Medications for Vulnerable Populations. Available at http://www.medicaid.gov/federal-policy-guidance/downloads/CIB-04-12.pdf. 5. November 21st, 2011. State Medicaid Directors Tri-Agency Letter on Appropriate Use of Psychotropic Medications Among Children in Foster Care. Available at http://www.medicaid.gov/federal-policy-guidance/downloads/SM-D-1123-11.pdf. The second resources slide is entitled Resources. Resources listed are as follows. 1. Faces of Medicaid, Examining Children's Behavioral Health Service Utilization and Expenditures. Available at http://www.chmud.org/publications3960/UMUD. 2. Making Medicaid Work for Children in Child Welfare. Examples from the field. Available at http://www.CHCS.org/USR_DOC/MEDICAID_WORK.pdf. 3. Customizing Health Homes for Children with Serious Behavioral Health Challenges. Available at HTTP://www.CHILDWITH_B_H_CHA LLENGES_P_IRES.pdf. 4. Psychotropic Medications Quality Improvement Collaborative, improving the use of psychotropic medications among children in foster care, available at http://www.chhtm.org/info-ur_doc. 5. CHIPRA Care Management Entity Quality Collaborative, available at http://doc.htm/doc/info-id=1250388. 6. Return on Investment in Systems of Care for Children with Behavioral Health Challenges, available at http://CHTTP://GUCCHD-AC-NTER/6-15-14.pdf. 7. Intensive Care Coordination using High-Quality Wraparound for Children with Serious Behavioral Health Needs, State and Community Profiles, available at www.chcs.org. 8. National Wraparound Initiative website, available at www.rtc.pdx.edu/NWI. And 9. Building Systems of Care, a Primer, 2nd edition, available at http://gucchd.georgetown.edu/72377.html. Contact information for Sheila A. Pires is sapires@aol.com.
Yes.
There is a pause because first question from male audience member is inaudible. Subsequent comments and questions from this individual are also inaudible.
Right. Yeah. In what state are you from? It's probably true. Okay. Okay. So what I'm going to say is probably true of a lot of states anyhow, so it doesn't matter. Here's the thing, which makes this even more challenging. There are very few people in state Medicaid agencies that understand this. Their many of them come out of a healthcare financing background or a health insurance background, which is it's a different headset than if you come out of service delivery and working with these populations of children and families. One of the challenges for Medicaid in general is that they're having to move from being just health insurers to actually being active players in determining the design of the service delivery system. So they need people at the table that understand what effective service delivery looks like for different populations of children. Those players tend to be providers and people like you who work in agencies serving children with child welfare, et cetera, in child welfare. You know, one of the things we've been trying to do is identify like a champion in these Medicaid agencies. It's not easy. In Illinois, big state, right? 2 lawsuits. I mean, there's a lot going on. New governor, no budget. I mean, there's just a lot going on. In Illinois, there's one guy who gets this, and he's a great guy. I've been working with him for a couple of years. He didn't get this to begin with. He understood like maybe this much. He gets this, and he's like this lone, and he's got, you know, like other stuff he has to do besides this. And like I worry about him. I worry that he's gonna, you know, drop dead or something. I mean, like, but it is a huge challenge, and it's frustrating for us in this world because there are capacity building entities out there. For example, Kennedy School at Harvard, they do like a little mini boot camp for new Medicaid directors, right? All this stuff I'm talking about, that's not on their agenda. It's basic, it's about adult populations, it's about health insurance, it's about healthcare financing. It's not about this. And it's just, you know, it's very difficult to get on the agenda. And it's very difficult to get the national foundations to focus on this. I've had these and I'm being probably more honest than I should be right now. I've had these conversations with Annie E, and I mean, I love those guys. I've worked with them for years. Commissioner Lopez comes from there. I think that this is one of the most critical policy things that's coming down the pike, that's here already in many states, that's going to affect our populations of children and families than I've seen in the last 20 years, frankly, particularly these integrated managed care arrangements. And it's so difficult to get people to pay, you know, the national entities to pay attention to it. This, you know, everybody's talking about evidence-based practices. That's great. I believe in evidence-based practices. But a handful of EBPs here and there isn't going to do it. We're talking about major systemic change in these Medicaid delivery systems. And you know, there needs to be, everybody needs to know this. And so, you know, I appreciate the question. I wish I had a better answer. So you have to find somebody in your state Medicaid agencies that, for whatever reason, is going to listen to this. Yeah. I'll tell you later. No, his name is Sean Cole. Yeah, he's going to kill me. I'm actually going to see him tomorrow because here's what we're doing. Through this Technical Assistance Network for Children's Behavioral Health, and we're a core partner of that, we've organized a meeting with the trade association. I feel like I have my back to you guys all the time. A trade associate with the trade associations that represent Medicaid managed care plans. So the key trade associations that represent them. We're bringing several managed care companies to the table who now are, for example, AmeriGroup that's managing foster care in Georgia, Centene that's managing foster care population in Texas, a number of these others, and Centers for Medicare and Medicaid Services. And we also have some child welfare folks coming to really launch a dialogue. We'll be covering all this stuff, but it's really to get a dialogue on and with state Medicaid purchasers. How can we change the trajectory around this? We don't want to 5 years from now have people turn around and go, oh, that integrated design that we thought made sense, it's not doing very well for our children in child welfare or children with significant behavioral health challenges. We need to regroup and start planning all over again. States are planning now. Some of them are already implementing, but you can always tweak contracts or they'll come up again. But many states are planning for 2016, 2017 implementation of these designs. So we're going to try to launch that conversation with them and keep something going so that everybody's at the same table instead of, trying to knock on the door from the outside all the time. Yeah. And I've had Medicaid direct, and I appreciate this with Medicaid. I mean, I understand it. They're under so much pressure. Who've said, we don't want to come to the meeting because we feel like we're already being pressured by this population and that population, this population. There are only so many hours in my day, So you really have to look for those win-win opportunities and find that one person in Medicaid that can be that champion. Yes, and right back here. Yeah, yes.
Hi, Sheila. I'm from Michigan, and our department recently transitioned with the Medicaid agency, so now we're together in one, and we've done a lot of work together with child welfare and Medicaid.
Yeah.
But I think, what's kind of really rising is all the practices around trauma and trauma-informed systems. And we've typically in child welfare used our general fund dollars to pay for different kinds of assessments and some of the treatment, although we're training up a lot of our community mental health providers in trauma treatment. But it's that door, that assessment door, that we've got some competing kind of parties, I guess, in our state about it. So, we're in the process of developing contracts for all different kind of trauma assessments, and ranging from what's called a comprehensive transdisciplinary trauma assessment to clinic trauma assessment to just trauma screenings. And I guess, is there anything being done on the Medicaid reimbursement level around reimbursing for some of these trauma assessments? And I think, one of your slides about the overuse of assessments, whether or not those are really necessary to be able to provide the service. So I don't know if that's enough to comment on, but just what's being done as we move into more trauma-informed care.
Right. So, again, you have to sort of be realistic here. Trauma-informed assessments make sense. They take more time, and they're therefore more expensive. If you don't pay the assessors in Medicaid a sufficient rate to do the assessment, they're not going to do it, or they're going to do a bad job. I mentioned Massachusetts as a state because of the lawsuit that mandated behavioral health screens using standardized tools. You could use a trauma-informed assessment screen as one of those standardized tools. They didn't mandate which screen to use, but to have to use a standardized tool. And they increased the rate in order to help finance the screen. It's not rich enough, frankly, the rate, probably, and they probably tell you that too.
The American Academy of Pediatrics does not recommend a standardized screening tool for foster children. They allow surveillance, and we've been going with that battle with our Medicaid agency. They won't make our providers use standardized screening tools because of the American Academy of Pediatrics permission to use the surveillance. That's another barrier.
Yeah, that is a barrier in that sense, and I'm talking more about standardized screens that address trauma and behavioral health needs, where you're backing into the screen not because the child's in foster care, but because it's a population of children that is at high risk for trauma and high risk for behavioral health needs. So you get away from the surveillance issue. But are there a lot of states doing it and paying an enhanced rate for that? No. I think as, trauma-informed, like integrated care, everybody's talking about trauma-informed care, but when it gets right down to it, if states are serious about actually doing trauma-informed screens and trauma-informed evidence-based practices, then they have to look for ways of resourcing it. But you can't also expect the Medicaid agency to pay for everything because, yes, they'll draw down a federal match, but they still have to come up with a 50% dollar to begin with, and many of them are in a deficit situation. So child welfare could put its dollars on the table with the risk entailed. That's why it has to be a good partnership in order to finance the match, its general revenue dollars. Because, Theoretically, it does not make sense for child welfare to spend 100% general revenue on Medicaid-eligible children for Medicaid-eligible services. It just doesn't, because you're missing the 50% at least match, and in many of your states, it's a higher match than that. Yes?
Hi.
There is a brief pause because comments from a female audience member are temporarily inaudible.
It's my hometown. I grew up in Chicago.
Yeah, we haven't seen you in a while.
Yeah, I know.
So we've made some progress since I last visited with you when you were out of town, and we were able to finance our, even for our babies, the child parent psychotherapy with state dollars and Medicaid dollars. Our challenge, though, has been utilization, and so for the agencies that are now providing that service, they're way underspending. For a reason you would probably guess, it's the actual contact time. And so I'm just wondering how you've thought about that or seen successes in other places around that challenge, because it's really, our providers are really feeling the crunch. They're probably spending 30 or 40% of the dollars that were allocated for them.
Because they can't provide this service
Face-to-face
in the allotted time.
Well, it's the clients actually showing up for the service. I mean,
So they can't engage the families. The rate's okay.
they're engaged, but not always at 3 or 4 times a month. And so,
Okay.
yeah.
Okay. Yeah. So, you could be partnering that with a peer support kind of approach. I mean, the literature that's coming out now about using like family peer support, peer mentors, et cetera, or youth peer mentors, it's very effective at engaging families, because so many families have a mistrust of the system. But you show up as a family with lived experience, and you can explain in your own words why it's important to come to 3 sessions and why 1 isn't enough. So I do think use of peer supports. I think we're going to see use of peer supports more and more, actually, because Medicaid and managed care companies are recognizing that in the grand scheme of things, it's a relatively lower cost service. So, and it is helping with no-shows, which cost provider money, engagement in services to begin with. You get families engaged in earlier intervention, et cetera, and then the deep end costs. So I think we'll see it more. Was there anybody else? Yes?
So how does this managed care Medicaid model compare with targeted case management? Is this targeted case management dollars that you're talking about?
How does what compare?
How does this Medicaid managed care model that you're talking about interface with targeted case management dollars? Is that the same?
Okay, so that's a really good question. So I was talking about an intensive care coordination approach using fidelity wraparound, for example, where it's a one care coordinator to 8. The supervisory ratio tends to be 1 supervisor to no more than 8 care coordinators. It's a very, it is a manualized approach in effect. There are a number of states that revamped their targeted case management and are using targeted case management to pay for that approach. There are other states, Oklahoma's one, where they're using that approach, what I just described, in their health home model, but they also have targeted case management in child welfare, right? Here's the rub, and they ran into it. Medicaid gets very nervous about duplication of function. So you have to be very clear about when you would, for a family, bill intensive care coordination under the health home versus targeted case management in child welfare. I think Oklahoma's still working on untangling that because it's not easy to untease. The other thing is, targeted case management really was intended as a more intensive care coordination model. And if it's not being used that way in child welfare, and there are some states, not to be named, who are using targeted case management really as a way to underwrite some of the salaries of their child welfare workers, which is not allowable in Medicaid on the face of it. So you really, in the one sense, it could be an opportunity for really revamping the model. On the other hand, you could, if you're using targeted case management in the right way in child welfare, you could turn that into a fidelity wrap approach, that subset of workers. You could go that route. Okay. Yeah, oh, yes. Is there time? Oh, we do? Okay. Boy, I must have talked really fast.
Tim Decker from Missouri.
Hi.
I have a question about the wraparound you talked about. I'm very familiar with Wraparound Milwaukee and their model. In that model where you have the small caseloads, are those workers doing the health and mental health and wraparound services along with the typical permanency and safety work that a child welfare worker would do, or are those two functions separate?
No, they're not separate. The child welfare worker is part of the child and family team plan of care. So they're part of the child and family team, rather. And so they're at the table together developing one plan of care. And so when the worker goes into court, the care coordinator from RAP Milwaukee is right at her elbow, and they're presenting to the judge one plan that covers everything. It's across life domains. So it's dealing with permanency, safety, housing, the parents' issue, and the child's issues. And it's one plan of care. So the worker in that case is very much an integral part of the team.
Well, and I was wondering because when you think about a caseload of 1 to 8, which is a very low caseload, we always argue for that. It seems like a lot to have a 1 to 8 caseload for a care coordinator, and then also have a full-time child welfare worker that's also working with the family. That's pretty expensive and a pretty intensive model.
The child welfare worker actually is not having to spend as much of his or her time on that family, because there's the care coordinator and the communication between the two of them is very close. I mean, they have very good communication protocols and mechanisms. So if a worker has 25 families on her caseload.
They shouldn't, by the way, but anyway, if they do.
Yeah, but get real, right? So 25 families on her caseload, and has 2 or 3 of the families I'm talking about where there's significant behavioral health stuff going on, lots of family issues, maybe also mental health or substance use issues in the parents. To have this capacity at your disposal, to actually be mobilizing this fidelity wrap approach, to have that capacity being chasing down all the services and have an organized provider network to actually pull them in place. To have that capacity be doing the day-to-day quality tracking. Is this working for the family? If it's not, let's reconvene the team. To have that capacity and worker come into court with you and say, Judge, we have one plan of care. That's why the judges like it, because instead of having everybody arguing and the judge saying, I've heard enough, we're going to do this, everybody is saying we're on the same page. If they disagree, there are well-established protocols in place for conflict resolution. It's a very different model.
I don't doubt that it's a great model. I mean, I've thought about that very similar model, to have someone really focused on the health and well-being and someone really focused on permanency and working as a team. I just wonder about you'd have to make the argument for the cost and the sustainability of it, because that's pretty intensive.
An integrated
if you have a traditional child welfare caseload for the child welfare worker and this additional worker, that's pretty intensive. And maybe all families don't need that. Maybe some do. Maybe all.
But you can make the argument that this is a worker with 25 families on her caseload, and it's not that you don't need her anymore. It's that she now has a resource that is going to be at her elbow to help with that subset of families that is taking up all her airtime, so she can't get to the other 20 families. That's really how the economics work of it. I mean, in real life. So, Yes.
A couple of questions. The first one is there a role for the federal government? Are there things that the federal government could do to be a matchmaker to encourage state Medicaid systems and state child welfare systems to work together? And then the second question has to do with, this is very complicated. It seems like the more we dig into it, the more complex it is. And I'm wondering if there's technical assistance available to states that are interested. Could a state child welfare agency contact somebody to help them figure this out?
And what was your first question
Is
about?
there a role for the federal government in encouraging state Medicaid systems and state child welfare systems to work together?
Well, yes, and the federal government actually has, the children's, for the first time really in my memory, the Children's Bureau and the Centers for Medicare and Medicaid Services in this administration have come together, looked at the needs of the child welfare population, have issued joint bulletins to state Medicaid directors around things like psychotropic meds, around benefit plans, around trauma-informed care, screening. Their Children's Bureaus, much more at that Medicaid table than they have been in the past. The technical assistance is an issue because you tend to have two worlds of technical assistance. The world that's providing TA around Medicaid redesign and health reform kinds of issues, and then the technical assistance around what I would call populations, child welfare, children with behavioral health challenges, youth and juvenile justice. And the knowledge base, there's not a lot of cross-fertilization in those two knowledge bases. So, there are a number of things. I know we in the Technical Assistance Network for Children's Behavioral Health have really tried to build a cadre of people that come from both perspectives. So we have a handful of people that kind of know about this, and I'm sure the child welfare TA centers do as well. But it's not enough people to kind of go around. So one of the things that state Medicaid agencies that I've been working with do sometimes too is they'll have, Medicaid agencies have these big consulting contracts with big companies like Mercer, for example. And they're coming in advising the Medicaid agency on an 1115 waiver, or on their larger redesign, with major implications for the child welfare population. The Medicaid agency will also, have either require them, or the agency directly will require that they work with a me or a Suzanne Fields or somebody else that has expertise in these populations of children. So that it's sort of a check on that larger consulting group. Which is, is just approaching things in a somewhat different, because they're paying attention to all populations. So, there's not enough technical assistance capacity in this arena. We really need to develop more. There are a lot of people in Medicaid agencies that know, well, there's some, that know the different options and waivers that you can use. So, and you all know what service delivery design features need to be built in, the types of services, the types of communication, things, the types of, that you can sit down with them and say, this is what we want to see in the Medicaid delivery system. And you tell us what vehicles, we can sort of have that conversation. But even there's just so much, different information across states and even across Centers for Medicare and Medicaid regions about what's allowable and what isn't, and it's kind of, you have to, it's an issue. What you're raising is an issue, I think. We need more technical capacity. I mean, we don't train people in our schools in this stuff. We're also launching a whole initiative with the deans of the School of Social Work, we're hoping to, around looking at trying to change curricula to, or affect it somehow to get more of this kind of stuff into curricula, more stuff around evidence-based practice, more stuff around the kind of systems issues and, financing. It's, people try to make financing and stuff really complicated. It really isn't that complicated. It can be taught and learned. So, I don't know. Yeah. I wish I was ending on a sort of more upbeat note. So, but it was his fault, and I don't know. Where are you from? Where were you from?
There is a brief pause because comments from a male audience member are temporarily inaudible.
Oh, okay. All right. So, thank you all. You've really been really engaged and creative.
The closing slide for the session presents the Center for States logo alongside a logo for the Children's Bureau.